going to talk about renal artery denervation for hypertension, and in particular, the rise, the fall, and the potential resurrection of this technique. Now, the history and the physiology of the procedure is well established. In this study, or this review by Dr. Murray Esler on the sympathetic nervous system, he makes the statement that evidence has been assembled in the past 3 decades, which indicates that sympathetic nervous system activation is crucial in the development of cardiovascular disorders, most notably heart failure and essential hypertension. And starting about 10 to 15 years ago, were a number of uncontrolled or non-randomized studies of renal denervation, which really showed 25 to 30 millimeter reductions in blood pressure. One of the first at the top was the Simplicity 1 trial. And if you look at the x-axis on the bottom, you see that with denervation, there was about a 25 millimeter drop in blood pressure. This was followed by Simplicity 2, which was a randomized trial of denervation, shown on the right, 30 millimeter drop in blood pressure with controls that were unblinded, no sham procedure, unblinded. And you see that the change in blood pressure and controls was almost 0. The third trial, Simplicity Hypertension 3, compared denervation in orange with a sham control arm in blue. And what you see is a significant reduction in blood pressure in both arms, including the sham control arm, and which was not statistically significantly different. And the difference between Simplicity 2 and Simplicity 3 was in the controls. In those with a sham arm, significant drop in blood pressure, and in unblinded controls, no change in blood pressure. You will also see that in the sham arm with the placebo effect, there was a reduction in the magnitude with denervation from 35 millimeters uncontrolled to about 12 millimeters or 11 millimeters. So Simplicity Hypertension 3 really shocked the hypertension world. We all felt that this technique would be successful. And the late Sabu Ramtula described the natural history of evolving therapies shown here. Progress, followed by excitement, euphoria. Maybe that's where we were 5, 6 years ago. Then a reality check, depression, and then everything gets placed into perspective. And I think we could say that after Simplicity Hypertension 3, the initial enthusiasm had been tempered, and the number of unanswered questions was increasing, but nonetheless, the concept remained of interest. Potential explanations for the lack of benefit in Simplicity Hypertension 3 included the following. It was the wrong catheter, operators were inexperienced, the power of the placebo, the Hawthorne effect, regression to the mean, drug adherence, which was a confounder, the use of office BP versus ambulatory blood pressure. Suffice it to say, all of these explanations probably were operative and contributory to some extent. But I think there really was general acceptance that technical issues may be important and need to be addressed, but a realization, again, about the power of the placebo and the importance of sham controls. This led to 4 subsequent trials, which took into account many of the limitations technically of Simplicity Hypertension 3. The Spiral trial, of which I chaired the Data Safety Monitoring Board, so I'm very familiar with this trial. Spiral off was patients off medicines after a period of washout. Yellow is renal denervation, orange is sham. And what you see is a statistically significant difference between the 2 arms of 5 millimeters of mercury in systolic blood pressure, 24-hour ambulatory systolic blood pressure. In those on medicines, 7.4 millimeter difference in 24-hour ambulatory systolic blood pressure. And in the Radiant Solo trial using an ultrasound-guided procedure, daytime ambulatory blood pressure reduced by 8 millimeters of mercury in all of these patients. So all of these trials, statistically significant. Now, this is a concern. This is the Spiral Hypertension off trial. And if you look at responders, 28% non-responders on the left with renal denervation, 52% non-responders with sham controls. But what is really quite striking is, as you'll see, some of the patients who responded had 25 millimeter drops in blood pressure, and some of the sham control arm had 35 millimeter drops in blood pressure. So we need to understand more about the non-responders and more about what it is that causes the blood pressure to drop in those who are in the control arm. So pivotal keys to the clinical future: identify responders, the ability to assess procedural efficacy. We don't have any way of doing this at the time of the procedure. How do we assess the durability of efficacy? Do we understand the phenotypes better? We need to understand the pathophysiology of hypertension is very variable, and which phenotypes are likely to benefit as opposed to those who will not. Other questions: how much blood pressure reduction is enough? Is 5 millimeters or 8 millimeters, 10 millimeters enough? And do we understand the real mechanisms of benefit? So to close, this is a cable sent by Mark Twain from London to the United States after he was having his breakfast at a London hotel, and he read his own obituary in the US press. And he sent the following telegram: the reports of my death are greatly exaggerated. I believe the reports of the demise of renal hypertension were greatly exaggerated, but there are still many unanswered questions that remain. I think that there has been some resurrection of this technique, but we still need more answers to many questions. Thank you.